All right, let's dive right into this capstone explainer for our human nutrition chapter. You spent this chapter really exploring the nuts and bolts of nutrition, and I know you just finished up those heavy-hitting videos on the female athlete triad and relative energy deficiency in sport, or REDS. So now, it's time to bring all of that together. We're going to synthesize the clinical and practical realities of eating disorder prevention and treatment. Let's get to it.
Here's the thing. We know the dangers of the female athlete triad. We know what energy deficiency does to the body. But as future health professionals, how do we actually intervene? How do we treat the underlying disorders causing all of this? Because, frankly, it's one thing to spot a physiological problem, but it's an entirely different ballgame to bridge the gap between identifying that problem and actually helping a patient heal.
So to answer that, we're going to cover 5 main areas today: the power of prevention, the multidisciplinary team, therapies for healing, matching levels of care, and finally, the reality of recovery.
Okay, Section 1, the power of prevention. Let's start at the very beginning of the recovery continuum, which is stopping these disorders before they even take root. Prevention is absolutely crucial. It's really about being proactive, especially in high-pressure environments. Early identification is our best tool. You want to catch those disordered behaviors initially before they spiral. We pair that with body image education to actively challenge the unrealistic beauty standards that athletes, and frankly all young people, are facing. And then we provide targeted information to parents and coaches to protect athletes from conditions like the female athlete triad. We want to anticipate the problem, not just react to it.
But what do you do when you actually spot a problem? It's tricky, right? If you suspect an athlete or a loved one is struggling, the National Eating Disorder Association, NEDA, has a really specific recommendation. It's all about interpersonal support using private, honest, and firm I statements. So instead of saying, "You aren't eating enough," which immediately puts them on the defensive, you say, "I am worried about you." See the difference? It expresses genuine care while firmly encouraging them to get professional help.
Moving right along to Section 2, the multidisciplinary team. Once we identify a problem, we have to realize that healing is literally never a solo journey. These conditions are deeply complex. They are simultaneously medical and psychological, so treatment is rarely successful in isolation. You need a highly structured team. You've got your dietitian for nutrition, a therapist or psychiatrist handling mental health, a physician to manage medical stability, and sometimes you even need pharmacy experts for medication. It's like a giant puzzle. You can't just treat the physical malnutrition and ignore the mind, right? Every single one of these experts is required to hold up the structure of recovery.
Section 3, therapies for healing.
Now, what tools are these mental health professionals actually using? Let's look at 2 foundational behavioral therapies. First up is cognitive behavioral therapy, or CBT. Think of this as a complete mental reframe. It's all about challenging unhealthy beliefs, like distorted thoughts about body image, and replacing them with realistic, grounded thoughts. CBT is actually considered the most beneficial approach for binge eating disorder. Then we have dialectical behavioral therapy, or DBT. This one takes a slightly different angle. It aims at improving skills to manage severe stress, anxiety, or feelings of inadequacy. It's really about giving patients the emotional survival skills they need so they don't have to resort to disordered eating to cope.
And listen, when we're dealing with children and adolescents, we absolutely cannot ignore the home environment. Family therapy is incredibly helpful here. It brings the parents and siblings right into the process, integrating the patient's entire support system into their recovery. So healing continues even when they leave the clinic.
Beyond traditional talk therapy, the multidisciplinary team might also tap into some really fascinating alternative therapies. Because eating disorders completely throw the body out of whack, you might see phototherapy used to regulate sleep-wake cycles using specific light wavelengths. There's biofeedback, which uses heart rate monitoring and neurofeedback to teach self-regulation. There's even equine therapy, literally working with horses to support self-discovery. And of course, general relaxation techniques, like meditation and acupuncture, are huge for managing the severe underlying anxiety that fuels these conditions in the first place.
Section 4, matching levels of care.
As we navigate this journey, we have to understand the strict criteria used to place patients into different care settings, because not everyone goes to a hospital, and not everyone can safely recover at home. At the base level, outpatient care is for those who are medically and psychiatrically stable. Their symptoms are controlled enough for normal life. Step it up a notch to partial hospital. Here, the patient is stable, but the disorder is actively impacting their life, so they need daily assessment. If outpatient fails and they are psychiatrically impaired, they move to residential care for round-the-clock supervision. And finally, inpatient. This is critical care for patients who are medically or psychiatrically unstable, often suicidal, with impaired vitals or lab work.
But honestly, regardless of which setting a patient is in, the ultimate goal is exactly the same: regain symptom control so the individual can get back to their life, engaging in school, going to work, and enjoying social activities. That is the whole point. Finally, Section 5, the reality of recovery. As we close out this chapter, we do need to confront the sober, long-term realities here. Recovery is a marathon. It heavily depends on a patient's readiness to change. And tragically, about 20% of anorexia nervosa cases actually become chronic. It's tough. This often happens because patients initially resist treatment or completely deny that a problem even exists. That is exactly why early intervention is so critical. But on a much more hopeful note, when we look at bulimia nervosa, approximately 60% of individuals show significant improvement when they receive professional treatment. So with the right team and the right tools, real healing is absolutely possible.
And for binge eating disorder, the path to recovery involves some very specific goals. First, utilize cognitive behavioral therapy. We talked about how great CBT is for this. Second, actively apply the lifestyle recommendations from the care team. And third, ultimately achieve a healthy body weight. That's the sequence for success there.
Well, that wraps up our final explainer for this chapter. You now understand the mechanics of the female athlete triad, the real dangers of energy deficiency, and the multidisciplinary frameworks required to treat eating disorders. So the question I'm leaving you with is this: armed with all this knowledge, how will you step up in your future health careers to intervene and support these vulnerable populations? Because pretty soon, it's going to be your responsibility to turn these clinical tools into life-saving actions. Keep studying hard, and I'll see you in the next chapter.